Hey guys, so I wanted to update you on Jace, his current situation, and sort of dive into the plans that doctors have for him in regards to recovery and the surgery process. Sorry it took me a little while to get this update to you guys. There's been a lot of changes in the past week and a half, so had I done a video earlier, a lot of the information would be inaccurate and I'd have to keep updating you guys, but now the doctors have a more solid plan as to what to do. So last week, he did have a couple of setbacks. In regards to his bowels, the doctors felt that he had the early stages of necrotizing enterocolitis, which is NEC, N-E-C. It has to do with the stomach and intestines getting invaded by bacteria and causing perforation and infection. So they had to treat that. They caught it early. They put him on some antibiotics that treat all kinds of different infections. But I guess the drawback to that, it delayed his surgery. So originally his surgery was going to be on Wednesday, and now we are scheduled with Dr. Mendeloff, the surgeon, on Monday. So definitely keep us in your thoughts for that. So we did get to meet with Dr. Mendeloff recently, and he allowed us to record a presentation going over Jace's specific heart conditions and the surgery itself, what he plans on doing, and a lot of that. So I kind of edited that up, summarized it a little bit, and wanted to show you guys, so that way if you had any questions or anything like that, definitely ask me and I'll be able to fill you in, and you guys can keep up with Jace. So thank you so much again for the support, and again, keep us in your thoughts on Monday as we go into surgery. Hopefully my next video here will give you a nice update. It'll be a good one.
All right, so now let's talk about what's going on with Jace. He's got a lot going on. And we'll start out by, we've got the two ventricles there, all right? He's got a large hole in the wall of muscle that normally separates the two ventricles. When there's a hole there, we call it a defect. So he has a ventricular septum defect, or VSD. Right? That's item number one. He's got quite a few things going on. Item number two is that rather than having an artery coming off each ventricle, instead both of these arteries come off the right ventricle, okay? Not only do they both come off the right ventricle, but they come off backwards from what they're supposed to be. So the aorta is here, and the pulmonary artery is next to it. So this is the aorta, and I'm going to call this PA. All right. Now, one of the things that I tried to illustrate, but I'm going to point out to you, is that, and it's even more drastic than what in fact I've shown you here, is that not only are those on backwards from one another, but the aorta is probably about, maybe about half, maybe a little bit more, the size of the pulmonary artery, okay? That means the valve is smaller leading into it, all right? The artery coming off of it is smaller. There is a bar of muscle that sticks down here on the echocardiogram, and that bar of muscle, I'm intentionally drawing it as leaning in this way, okay? Because that's what it does, all right? Now, I drew a smaller aorta comes up, it gives off the first two branches, and it ends, all right? So the two arteries coming off here, off the same ventricle, are double outlet right ventricle, meaning both, these are called the outlets of the heart, both outlets come off the right ventricle. The fact that they're switched around with each other is called TGA, or transposition. Of great arteries. So, and this is, we call that a deviated conus. I won't put that up there, but that's just a bar of muscle that sticks down. But it comes into our decision making, and that's why I put it in there. Well, if the aorta comes up and ends there, that is yet, so we've got 1, 2, 3, now 4 different heart defects in one. Interrupted aortic arch. All right. So the aorta comes up and ends there, and so obviously the next thing you say to yourself, well, I mean, how's the rest of the body getting blood? I'm going to show you that now. Coming off the branch of the artery that goes out to the left lung is a blood vessel that we are all born with called a PDA, or patent ductus arteriosus, all right? When I say we're all born with it, we are, but it typically closes up in the first, week or 10 days of life. But this is what Jace has, all right? So 4 different heart defects in one, all right? And obviously that's a big, big, big deal, all right? Now, let's look at how his blood is circulating. Blue blood comes back from the body like it should, all right? It comes in here, and then it has 2 places that it can go. It can either go out that way, or it can also go out this way, all right? It can go out both arteries, because both arteries come off the right ventricle, all right? The blue blood that goes out into the pulmonary artery can go out to the lungs, but it can also go through here to go through the PDA and get out to the rest of the body. Now, ideally, we're not supposed to have blue blood going to our body, but it's okay as long as there's red blood that's going with it, and enough red blood that's going with it. So the good news is that the blue blood that is coming out through the pulmonary artery and that is going out to the lungs is getting out to the lungs and getting oxygen. And where does red blood from the lungs come from? Well, it comes, where does it go to? It comes back here. It comes into this left ventricle, right? Now, there's no artery off this left ventricle, so where that blood is going the only place it can go, and that's through this hole and over to this side of the heart. Once it reaches this side of the heart, it mixes with the blue blood so that he has both blue and red blood basically going out both places. So he has a mixing of blue and red blood. And that's fine, again, as long as there's enough red blood making it out to the body. Right? So, and this is his current setup. Right now, I think as you guys understand at this point, what happened is he went home from the hospital without this diagnosed. This PDA, as it's prone to do, started to close up. Mm-hmm. Right? When this closes, that means this is really the lifeline to the entire lower half of the body. Right? Intestines, kidneys, liver, everything down below, blood is going through this PD. Because the arch is interrupted, blood going out here doesn't get over here, and so this is the only pathway for blood to get to the body. And that's why when he got sick on you, so once that PDA starts to close, it's bad news, all right? And unfortunately, got him to the hospital in time. They started him on a medication called prostaglandin E, all right? Prostaglandin E will keep this blood vessel from closing, all right? And so that kind of saved the day on him, got things turned around, but his body had been through a very, very big and major stress, all right? All right, so what can we do to help make this better? So let's start at the top here, where the interruption is, all right? This is a big deal up here because obviously blood can't get out and get to the body. We can't, he's not going to go home with the PDA open, that won't stay open. So we have to find a way to get blood out into the body, all right? So that means bringing this together with this, all right? In his body, they're actually quite a fair distance apart, all right? They're about as far apart as I've seen. I've been doing this for 22 years. They're about as far apart as I've seen in a baby, all right? Nonetheless, we've got to make this and this get together, all right? We also have to address that really this pathway for blood leaving the heart looks too small to be an adequate pathway. So what do we do when we have that situation? We're going to take this artery pulmonary artery, and I'm going to divide it. And what I'm going to do is partially sew it into the side of that much smaller artery. We're then going to, I have to mobilize this whole part of the aorta down here. We're going to cut the PDA because it can't stay there anyway, all right? It's going to then leave an opening here, all right? I then will make an opening here all the way down so that basically what we have here, I'm going to take this and pull them together, which will be a big challenge. I can sew them together up at the top here, but there's still going to be basically the rest of the opening there, right? What I'm then going to do is I'm going to sew a patch, and that patch is going to come down like this. And come to there, all right? By doing this, we've created continuity here. We've created a blood vessel. It's really the combination of these two that's big enough to carry a good amount of blood out to the body, all right? Does that make sense? Okay. Now, we still have the branches, right? I disconnected this artery, so there's going to be an opening here. Okay, that's where the pulmonary artery was connected before. I can just put a patch here, all right? So there's not an opening there. But the question is, now we've created a nice reliable pathway of good size for getting blood out to the body, all right? But we did that at the expense of using the artery, the much larger artery that was carrying blood out to the lungs. So how are we going to get blood out to the lungs? We're going to sew a little graft. This is what's going to happen. Blue blood will come back, it will come in here. It has two pathways that it can go out. It can go out either this pathway, which is where most of it's going to go. Some of it will go out this pathway here, it's smaller. But the bottom line is, either way, it's going to get out into the aorta, all right? It will go out here, but it will also come here and go down that shunt, all right? The blood that goes down to the shunt's going to go to the lungs. It's going to get oxygen. Red blood's going to come back from the lungs, come back here, go through this hole, and basically some of it can come over here, but really most of it's just going to go out this much easier pathway. With doing this, he will still have a mixture of blue and red blood going around the body. That's okay. He can go home, eat and grow with that. They do fine as long as they had enough oxygen going to the brain and the body, the rest of the organs do. He's got mixing right now, all right? So the fact that he's going to go like this for about a year is perfectly fine. But you see that by doing this, number one, we create a much better pathway, much more reliable pathway meaning reliable size, for blood getting out to the body, all right? We have a way for blood to get out to the lungs, all right? This won't close. He'll slowly outgrow it, and once he slowly outgrows it, we'll get to the point where we'll come back and do a second operation. We'll talk about that in a moment. He has his aorta in continuity, okay? Pictures. So this little graft here, it's just a piece of synthetic tubing. This is what it looks like. It's made out of Gore-Tex, okay? Synthetic tubing, completely non-reactive, nothing his body will reject or anything like that. But it also gives you kind of the size magnitude difference of what I'm drawing on the board here and what we really use. For this, we would only use a short segment of this. The graft I use will be maybe a half a millimeter larger than this, but half a millimeter is not very much.
Yeah.
So this is the reconstruction that we're planning on for Monday, all right? So we call that repairing the interrupted aortic arch, all right? We're going to deal with the size mismatch here. Sewing these two blood vessels together is called a DKS. That's just a surgical terminology, and it's far more important that you just understand what we're doing, all right? So that we have nice unobstructed flow into and around the body. Nobody can live without that, right? And that's what and then we will have blood going out to the lungs, okay? What we will do at a second operation, and I'm not going to cover this real extensively right now because when it's time for that, you guys will come back, we'll sit down again and go through it, but just for completing the story, is that we will come in here, I will sew a patch in here, okay? And then I'm going to have, because this artery really was never big enough, I'm going to have to sew an artery in here, and that artery will actually from the right ventricle here, and I'll hook it in to the pulmonary artery out there. And when we do that, then blood will come in here and we'll go through this artery and out to the lungs, and then there will be complete separation of blue and red blood, all right? And again, we'll usually do that at about 9 to 12 months of age, all right? And that's a better time to do that anyway. This artery that I put in there is obviously not his own artery, and it won't grow with him, but the bigger he is, the bigger artery I can put in there, all right? But this is a way that he will still, in the long run, have blue and red blood separated from each other, which is how we are meant to be, and how our heart functions most efficiently. So blue and red blood will be separated from each other, and he will have a separate ventricle. This one will pump red blood through the hole out into a nicely reconstructed aorta, and the blue blood will come from the right ventricle and out to the pulmonary artery, all right? So the reality of it is that hole, that ventricular septal defect, we don't ever close, all right, in any of these kids. It's the only way that blood can get from this side of the heart over out to where it needs to go out of the heart. Again, we're not able to plug an artery in over here, all right? That's just impossible to do, all right?